Thank you very much. I will speak a little bit about treatment, about obstructive defecation. And it is very important, I think, when we speak about constipation, that we realize that this is very common. Nearly a third of the population does have constipation, so we should select our patients very carefully. And most patients should not have surgery. Most patients should actually have something much less. Dietary advice, laxatives will come a long way with. And some patients we will then evaluate a bit further. If they have handicapping symptoms, we need to do a colonoscopy in most of them to see that there is nothing else. And we should try conservative treatment in almost all patients before you consider surgery. And we've heard about evaluation before here, and as we've heard, what we come up with many times in obstructive defecation patient is that they either have a paradoxical contraction, they have a rectocele, and rectal intussusceptions. These three findings are quite common in the patients we work up, and some patients will have 2 or 3 of these conditions at the same time. There is a lot of different treatments we can consider. We've heard about some of them, and I will not discuss about slow transit constipation. I will not discuss biofeedback, and we've just heard about STAR, so I will also skip that. So I will more discuss what role does a rectocele repair have, rectopexy, and very short about SNS, which is kind of surprising. Could it work for this as well? I think that rectocele repair should just be remembered. It's something that is still fairly often done. We don't really know. My preferred way, if I do it, is to go through the vagina or in the perineal area. The colorectal surgeons also do it transanally. It is very confusing. Should we do the traditional posterior colporrhaphy? That gives us more dyspareunia, or patient more dyspareunia. Should we not use the levators and use just the fascia? That has a higher risk of recurrence. There has been several years now where it has been advocated that we have to use a mesh to fix a rectocele. And as you know, many of these mesh kits have its problems in the United States right now. There is a lot of hesitancy of using mesh for this repair, therefore. This is just the posterior colporrhaphy, and I just want to remind you that you can have good results. This was a study we published 15 years ago, where you see most patients did have quite a bit of obstructive defecation, and after surgery they were good. And we repeated the study 4 years later, and it was actually sustained. So this does work, and don't forget the old traditional methods that can actually work. And then rectal intussusception. Could I get a click, please? You've seen it before. Un click, por favor. And you see it on defecography. You can see it also on ultrasound or MRI. And you see how the wall will intussuscept here, and you have a rather clear rectocele there. You could do a rectopexy for this. That was tried 20, 30 years ago. This was the experience we evaluated back at Karolinska when I was there. And this is rectopexy, the posterior rectopexy for internal intussusception. And this is one of the reasons we did not do it any longer. So this is 10, 15-year-old data, but you see that if you operate for internal intussusception, there are very few patients who actually get better. You have a good proportion of patients who still have, understand me correctly, when you evaluate them, they don't have the internal intussusception anymore, but their symptoms are the same. And you see that many are unchanged, and actually we had more patients who were worse off with their evacuation than they were before. And therefore, I don't think that posterior rectopexy is a really good surgery for internal intussusception. Well, then you come this laparoscopic ventral rectopexy that seems perhaps to offer us a better result. I want you to, however, caution you. I'll review a little bit of the studies we have for this. But this is a rectopexy where you don't touch the posterior rectum. The only thing you do is to mobilize in the front here, and you put the mesh. And I agree with Dr. Ortega. The big question is, should this be a synthetic mesh or should it be a biologic mesh? And I can see risks with both of those, but different type of risks. And you just lay the mesh here, and you suture the mesh to the front of the rectum, and you anchor the mesh up at the promontory. And you can do this laparoscopically, you can do it open, and it's also an interest to do this robotically. This is one of the studies which came out from, this was the original study by DeHoor, and they had 42 patients, and they had usually patients with external rectal prolapse. They had no major postoperative complications. They had recurrence in 2 patients. And when you looked on the ODS patients with defecation, there were 19 of them, and they reported that the obstructed defecation was better in 16, which is significantly better than the posterior rectopexy. They did have mild de novo obstructed symptoms in 2 patients. There are a couple of other studies. This is another Dutch study where they had 17 patients, and they had improved symptoms in many patients, and 9 had resolved defecation problems, and 6 had minor constipation symptoms. They did have some complications that you can see here. And here you can see with the ventral rectopexy, you can see that the incontinence score did improve at the same time. And here, this is from Lindsay's group in the UK. This is their study, 65 patients. And they did not initialize. I had the pleasure to meet Ian Lindsay a few weeks ago, and they are now looking more into obstructed defecation patients at Oxford. But what they have published so far, you can see that they had 49 patients that in their study had mixed obstructed defecation and fecal incontinence, and they only had 12 patients in the original paper with only obstructed defecation. But what they do report is that they have improved obstructed defecation in a majority of patients. And the question is if this will be sustained if you do more pure obstructed defecation patients. There are not many in the literature yet, and I think we need to wait for more studies before we can say that this is something we should do. And also, as you know, rectal intussusception has different degrees. What they operate is only what they call grade 3 and 4. It's an internal intussusception that goes into the anal canal. These small falls you can see sometimes higher up in the rectum, you should probably not do with this surgery. This should be rather advanced rectal intussusception. So don't go home and operate on everyone. Very short SNS. I just want to say that SNS has been used for constipation. In Europe, it is approved for this. In the United States, it is not. And the study we talk about is a few years old. It was published in Gut from 5 European centers. They had 62 patients. Most of them had slow transit constipations. And they had implant criteria when they tested that they either had to have more bowel movements or less straining, or it would be easier to evacuate. And results really depend on what you require. It's somewhere between 33 and 87%. If you require that one of those things should get better, then it's 87%. If you want to have all those 3 requirements to get better, then you're down to 33%. But if you look on their chart, you will see that the patients with successful defecation did increase, and you will You see also that how much time they spent in the bathroom did decrease. And this is something that will work, and the attractive thing with SNS is obviously it's a safe thing that you can try in patients. If it works, it works. It's still costly, but a good example is that half a year ago I got a phone call from a Swedish woman who had moved to the United States, and she had discovered that this was not covered, but she had got it back home in Sweden, an SNS, and she was a candidate for a colectomy, and they said that, well, let's try SNS first, and she was completely relieved of her symptoms. Her concern was that she can't really get help with this treatment in the United States. So there is something there. We don't know how it works, but that's how it is. So conservative attitude, rather operate fewer patients than more patients. Surgery is indicated in select cases, whether you should staple, whether you should do a ventral rectopexy, SNS if you can afford it and get insurance to pay it. I don't think we are really there today, but it's certainly a very dynamic area. And finally, perhaps we have a few options to offer these patients, because we have patients, all of us, that have these problems. Thank you very much.
Muchas gracias, doctor. Por cuestiones de tiempo nos obviamos lo de la sesión de preguntas y respuestas. Me imagino que nos vamos a quedar, se van a ver ahorita las reuniones de sesión de negocios, tanto aquí en la sala 1 del Colegio de Mexicano de Especialistas y también de la Sociedad en la sala 2. Muchas gracias.
Les pido a los socios del colegio permanecer en esta sala para dar inicio a la sesión de negocios. En la sala adjunta, que es la número 2, ahí es la sesión de negocios de la Sociedad de Cirujanos de Recto y Colon.